Hello and welcome back. I am Charlotte Canley from Birth Essence, and today I'm welcoming Dr. Amali Lokugamage, who is an obstetrician and gynecologist and the deputy lead for clinical and professional practice at UCL Medical School, which I think it'd be better if you explained what that was. I've written it down, but welcome today.
Thank you, Charlotte. Thank you.
Yeah.
Oh, about clinical and professional practice, it's the part of the medical curriculum of UCL Medical School that involves training doctors in not only interpreting scientific data, but also the professional aspects of kindness, compassion, being ethical, and communication skills. So it's sort of the medical humanities bit of medicine and science.
I really love that. I think that's what makes the biggest difference whenever you're in a medical setting, the compassion and kindness that people show you, the humanity. So I'd love to talk to you today about birth, and I know you do a lot of work on decolonising birth in your jobs. I'd love to speak about that and things that I hope will be inspirational for women listening today.
Okay. How would you like me to proceed?
I'm guessing that, what does it, I know that I've heard of that and I thought that's interesting. So what does it really mean, decolonising birth? What is it exactly?
Well, I suppose decolonising anything is an issue that's been around for a long time and could be considered sort of part of equality and diversity and inclusion. But it's far more active in terms of overturning power imbalances that have arisen through historic and institutional biases that are around class, race, gender, disability. And I've been doing a bit of work in terms of looking at decolonising the medical curriculum. Mm-hmm. However, as an obstetrician, my attention also turns to maternity care, and that's how I came to develop this talk, which I gave to a Maternity Voices Partnership group at an NHS England meeting quite recently.
Mm. And that sounds really interesting. Is that the talk that you have these slides that you were mentioning?
Yes. So I do have a talk called Undoing Systemic Biases and Privileges in Maternity Care. Would you like me to take you through that?
I would really love to hear about that. I really would love you to take me through that.
All right. I'll share this with you and hopefully I'll be able to give you that talk.
Yeah, excellent. Yep, it's working.
Okay.
Excellent.
So here we are. My about this area comes from the work that I've done at UCL Medical School in general medicine and education of doctors. But it's all about really undoing systemic biases and privileges. That means the kind of institutional biases and those people who are privileged through it, and how it affects women and the autonomy of women who receive care. So in this talk that I gave, I talked about power imbalances in healthcare, the maternal mortality rate that reflects a higher mortality rate for Black women and for Asian women in the Membrace report, and similar sorts of statistics coming from America, which in terms of decolonising maternity care is a reflection of the impact of those biases within the system. Also, I am very much in favour of trying to develop within maternity care a cultural safety model of care, and I can talk about that a little more in detail later on. And also in the conversations about decolonising anything, be it science or government or anything, there is a conversation around privilege fragility, which is about the fragility of people who hold the power, and when confronted by the fact that the system is biased in their favour, kind of refute it, don't say that it doesn't exist because they don't see any evidence through their perspective and through their lens.
Yeah.
So yes, as I referred to, clinical and professional practice, and all medical schools have this to a greater or lesser extent, but it's particularly well developed at the medical school I work at. We're trying to, look at overarching themes and look at professionalism and be person-centered, and also look at communities, the individual, and as I said, compassion and kindness at the root of this. And this is all part of developing professionalism and integrity. And this is so much more advanced than when I studied medicine about 30 years ago, where it was all really about the science. However, the kind of council that looks at behaviours of doctors and looks at the behaviours that we have to create in new doctors, the General Medical Council has laid down some guidance about how we should produce doctors that have the skills to advocate for those who are disempowered, and to recognise those sort of sociological factors that contribute to illness and the treatment, and understand the issues related to healthcare inequalities, and obviously take into account environmental, social, behavioural and cultural factors that affect the different populations that we all as healthcare professionals serve. And we've certainly done our project work with students, co-creating pedagogy is a sort of scholarly way of talking about education and the knowledge around it and the research around it. And at UCL Medical School, well, in fact, at University College London, which is not just a medical school, it has all the other types of subjects and is a very old English university. And I suppose it was set up in colonial times, and it has colonial issues that need decolonising. But for some years, an initiative called Liberating the Curriculum has been set up. And it's quite direct, actually, in just stating that this initiative, which filters across all of the faculties, is about challenging the traditional Eurocentric, male-dominated curricula to ensure the work that marginalised scholars on race, sexuality, gender, disability are fairly represented in the curriculum. So that is a fairly direct statement by an overarching part of the university that I work with. And so we had a project, and we won a grant to liberate the medical curriculum and look at diversity. And it's all really from our perspective about person-centered care and wanting to have a broad curriculum with diversity, equality embedded within it. And really, this resonates with a wider global movement to challenge and flatten power hierarchies, and medicine has always had power hierarchies. So it's quite a pioneering role in terms of all universities, and UCL playing its part in that. So we in any work that affects the public, I think we were pretty sure that we wanted to involve the public as part of agents of change, as well as students. And so we had a sort of public engagement event, and we also mapped our curriculum and to look at whether the kind of teaching content contained stuff on challenging hierarchies, diversity, sexuality, LGBT, and we produced a kind of map which looked like this. But it's quite interesting. This shows that most of that work goes on with a patient experience, all the kind of teaching episodes that use the patient voice. So that's why it's really important for women and patients to get involved in this aspect of advocacy, because your voices change change the system and change the outlook and perception of doctors. So we did that sort of health check, we called it, on our curriculum. But in any area where you're dealing with people who have been marginalized for a very long time, you can certainly make mistakes, not realize that you've hit on areas of sensitivity. So, we really realized that we had curiosity and courage, but you have to have quite a lot of humility in navigating through these sort of kind of ingrained power imbalances. So again, UCL has been quite forward thinking, and a lot of the decolonizing work refers back to, for instance, this work on by the arts and humanities, which was called "Why Is My Curriculum White?" I mean, I found these incredibly daring in terms of being very direct about the fact that a lot of arts and humanities curriculum, the knowledge base is mainly from white authors and not people of other colours or cultures. So so that's the central kind of knowledge which graduates have, and they input that into society wherever they go on from their education. And then there are quite some outspoken scholars, for instance, Primaveda Gopal from Cambridge, in this Guardian article saying, yes, we must decolonise our teaching. It has to go beyond white elite men. Again, very direct language. So this is not my own language. This is what is out there. And quite a few articles about universities must decolonise the curriculum because there is an attainment gap. Students from Black, minority, ethnic, BEMA background do not get as higher grades as white students, and people are trying to untangle why that is so. And on the back of that kind of public engagement, we had feedback saying, why don't you decolonize the medical curriculum? And at that point, I'd not really heard of the term, even though I was born in Sri Lanka, which is an ex-British colony. And actually some of my colleagues hadn't heard of it, and they thought that decolonizing might have something to do with bowel bacteria or something like that. So such was our ignorance at that time. This is sort of early 2018. So we thought, well, let's hold a public engagement event and learn from the public, and we'll call it Decolonizing the Medical Curriculum, and explore well, we'll present what we do, and then we'll see what other people think and what's missing. And it was interesting because at that time, the Welcome Collection, which is an exhibition and also a leading funder of biomedical research, had an exhibition called Ayurvedic Man, and they also had a symposium called Decolonizing Health. So we were invited to speak and talk about what we have done at UCL. It was very interesting to hear the perspectives of museum curators and other people, and there was a lot of learning, and part of it influenced our eventual event, which we divided into two areas. A historian came and talked about decolonizing the hidden medical curriculum. So the hidden curriculum in education is I suppose the bit that isn't obvious, the bit that isn't in the written material or in the sessions. It's the bit that comes over from it's the unworded biases, language that's used by the teachers, the settings, and it kind of programs people without them knowing. Okay. So we looked at that from a historical basis, and then we had kind of a what we called it a speed dating with medical education, and it doesn't sound as saucy as it sounds, but it was just 4-minute bites we just gave people to talk about decolonizing the body, decolonizing the curriculum, decolonizing the learner experience, decolonizing the actual educational space, decolonizing professional behaviors, and decolonizing ideas of healing. And I'll talk about that in more detail as I go along. So power hierarchies, if you're looking from a historical context, you can see from that picture, it's a bunch of, I suppose, unicoloured men around an inanimate object. And we have to really understand that colonial attitudes have insidiously influenced education, attainment and patient care. That's part of the hidden curriculum. And the historian who spoke, Dr. Lindsay Porter, did say that the 18th century Enlightenment was very important for the development of science and the analysis of things and the overturning of superstition and so forth. But it led to objectivity and subjectivity, a divide. It made things all objective. And when you objectify people, you lose the human connection between them, and that can lead to dehumanization. And so this is exemplified perhaps in one of the big stories in decolonizing maternity care, the story of Marion Sims, who was actually an American gynecologist. I mean, he has been labeled father of modern gynecology, but that may be by Americans. But he invented this speculum, which is used for actually sort of prolapses. But he experimented on Black women slaves to get this knowledge. And here's a picture of this. They were very dehumanized experiments. These women were not anesthetized. Anarcha Letzi are the most well-known of the slaves that he experimented on, but many women have disappeared from history books, so we do not know the extent. But they were experimented on while they were awake. They had surgery, their female anatomy was cut, and they also developed injuries from surgeons trying to learn the use of forceps. So this is a very kind of keynote colonial episode that shows that we should have some, I suppose, professional humility about the way in which we have derived the knowledge that we have in maternity care. Sorry. So I said I'd go over the kind of decolonizing the body, decolonizing various aspects, and these were the key points actually that we looked at in terms of decolonizing the body. Are we teaching students to pick up illnesses in Black skin? Are we teaching them to pick up that there's no oxygen cyanosis in white people? You can see blue lips or blue nails, because could the excess of deaths in Black women be because you just can't pick up that they're about to die? You know, their symptoms aren't that clear. I think the same applies for things like mastitis. Looks very different in Black skin than white skin. And also we talked about sessions that we have in the syllabus about feminist pedagogy, that's teaching, and we use patient stories to look at various aspects of violence against women. We map the curriculum, and I've talked about that before, and a group of teachers from UCL also looked at the attainment gap and students' experience of racism. At UCL, we have commemorated very famous scientists who discovered, say for instance, meteorology, Galton, and was a contributor to our knowledge in statistics. But he was also an advocate of eugenics, and so many students have been upset that the buildings celebrate him, and so we have an ongoing eugenics inquiry about whether the building should be renamed. And some students feel that in terms of anthropology, which is a way of looking critiquing medical knowledge, and some students want us to include more anthropology, kind of critiquing our behaviors of doctors. And also we touched upon the fact that biomedicine, Western biomedicine, has colonized indigenous ideas of healing. For instance, Ayurvedic medicine, or Chinese medical, traditional Chinese medicine, or some ancient systems where the legitimacy of that type of healing has been diminished by Western biomedicine, and the of indigenous knowledge, not just in healing practices, whether it's agriculture or just looking after the planet, has been displaced. And decolonizing means recentering that knowledge. And so from those events, we have, tried to develop teaching sessions so that we can help students to see cyanosis, which is the blue coloration in Black patients that might have low oxygen. And also in skin conditions, we develop stickers looking at, say, for instance, cancer stickers that represent what skin would look like in darker skin tones. And then also we have to acknowledge that some laboratory tests are different have different normal ranges depending on what ethnic group you're from. And so I have seen on Twitter that people complain saying that's racial profiling, or it's actually racism to say that people are different. But then if you think about it, if you're being overdiagnosed or underdiagnosed because of a blood test and they haven't adjusted for the normal ranges of your particular ethnicity, you can either be undertreated or overtreated for a disease. So it is very, very important. Okay. But further areas that, from listening to more decolonizing conversations from other institutes, are things like intersectionality is a term. Kimberly Crenshaw came up with, a Black feminist, about the multiple oppressions that women who are Black face. So the intersection of their oppressions, and the term intersectionality hasn't really been incorporated into our teaching of what we call social determinants of health. So perhaps we should use the terms that women have chosen to describe the challenges they face. And in terms of reflective practice, which is what doctors are supposed to reflect on the care they give, and if things go wrong, to reflect on that, if they make errors, to reflect on that. And if you're thinking about decolonizing it, actually, I think the Montgomery versus Lanarkshire ruling, which Judge Hale says there's no place in care for paternalism. That is a law that is effectively decolonizing or changing the power imbalance between practitioner and patient. We've also got to, in healthcare, there is a certain body of knowledge that people refer from. But really, if you look at it historically, that body of knowledge only comes from certain places, and I'll show you a slide of it. And there is they've called it a geographic bias, but it's really a kind of colonial bias from where knowledge comes from, and the knowledge from indigenous people or other colonial communities do not feature in the same sort of way. There's also a conversation that's being held about transgenerational mental health trauma from those people who've got an ancestry of slavery. And I think transgenerational trauma has been talked about in even sort of Holocaust ancestry. And so that is something to be taken into account. And in terms of LGBTQ, in terms of decolonizing, all the colonial laws were anti people expressing the variations of sexuality. And in some countries, even though a lot of the discrimination is being overturned in law in the UK, in some of the countries that were colonized, they still have the death penalty for having different views on or different practices on sexuality. And then there is the kind of conversation, and I put midwifery into this, about well-being. Anything that puts the body into balance, physiology and midwifery. There has been a sort of a colonial takeover of those practices as Western biomedicine being a more, as I say, a more legitimate form from a historical background, and those kind of imbalances are now starting to be overturned, and conversations are happening along those lines. And also conversations about cultural appropriation, and that is when a dominant culture uses the practices of a culture that has been historically oppressed, and they present it in a way that isn't culturally nuanced.
Mm-hmm.
But the black mothers dying at a rate that is higher than white mothers, and Asian mothers too, not as much as black mothers, say twice as likely as white women, and black women 5 times more likely to die. A lot of obstetricians have talked about it in terms of black women having a greater propensity for having high blood pressure or preeclampsia, or brown women having more gestational diabetes. But really, I would say that the conversation from black feminists that has really, I suppose, through social media, hit our kind of our radars is on the back of high-profile black women like Serena Williams saying that she wasn't listened to when she presented with symptoms of pulmonary embolus. She diagnosed herself, and then being a powerful black woman, a lot of women come forward continually with these stories of when they go into healthcare, they're not listened to. So one really has to, whatever you think about the increase in pathology, people of darker skin, you have to take on board the fact that many women are saying that they're not listened to. And this is actually not only in maternity care. In UCLA in California, Dr. Maria speaks about this at a kind of an event that they had. I'm just going to play this for you, and this is just talking about cardiac mortality in women, and this really exemplifies how you can challenge the biases that you have. And I think she actually in this conversation describes cultural safety in describing that she challenged her own biases, and if she hadn't done that, a woman wouldn't have been listened to. So I'm just going to try and play that for you. Oops. So that, I mean, all of the issues around that led me to publishing a BMJ blog, saying that I really think that this reflective process, cultural safety, is something that we could hopefully incorporate in the future. It's a nursing model at the moment, and there isn't much written about it in medicine. But I think, you know, this process of reflecting on power imbalances is very important, and you can see from my interest in clinical and professional practice how I kind of trod this path to and got this perspective, and also in terms of cultural safety, from this publication, uh, it is the realization of health professionals about power in any interaction, that any interaction between themselves and colleagues, or themselves and patients, there is a potential for disparity and inequality, and one has to really understand that and modify your conversation, and the way in which you offer knowledge and negotiate what the patient wants has to have some understanding of that. So is cultural safety any good? Um, there are studies on cultural competence, and we're not quite sure whether it works. But in cultural safety, there was this publication relatively recently looking at ex-colonial settings, saying that really they did find that it was linked to improved relationships and healthier outcomes. So I'll refer you to that. And in the previous video, we talked about implicit bias, unconscious bias training, and colleagues have asked me, do you think that works? And unconscious bias is these kind of unconscious views that we're unaware of, that are activated and operate outside our awareness, and we pick those biases up through our background, culture, and context. But does unconscious bias training work? Well, this publication from the Equality and Human Rights Committee actually says that the quality of unconscious bias training is variable, and as yet they haven't proven that it actually makes any difference because of that variability. And then explicit bias is just being really frankly biased or racist or prejudiced. And can you change that? And that also is very hard to do, because most people tend to think that they don't have explicit prejudice, and they are unlikely to disclose it if they have, and so that also is very difficult. So that's why I'm leaning towards cultural safety. And earlier on, I referred to the fact that Imperial College London have done a lot of work saying that there are geographic biases about the actual foundation of healthcare knowledge, and that really, in terms of what goes into guidance textbooks, really just come from prestigious institutions from high income countries and from certain sectors of society. So if you look at, say, this diagram from a publication by Pan et al., it shows that most of the knowledge that actually goes into midwifery textbooks, medical textbooks, or just, you know, healthcare textbooks, come from one type of area, you know. And so if you were from say Africa, it has hardly any real representation in terms of the knowledge in textbooks. And this is also seen in looking at decolonizing disability. We have migrants that have come from war-torn countries, and so in terms of impaired peoples, there's little depth in terms of how civil war strife, nuclear testing, the growth of the arms trade, pollution havens, sweatshops, all of those things affect disability. It's all basically very sort of Anglo-centric disability. And if you talk about disability and mental health being a disability, I think a lot of colonial mental health arenas, Hawaii, for instance, New Zealand, Australia, Aboriginal work, and in Canada, have shown that when you're dealing with the mental health of people that are from other countries or are indigenous of people, that in trying to solve their mental health problem, you can't just throw drugs and the usual cognitive behavioral therapy, mindfulness. You've got to put their mental health treatment in their cultural setting. It has to be aligned with their cultural identity, values, and beliefs. And in this way, for instance, in this Hawaiian example, where there's a high suicide rate in adolescent girls, that when they did culturally center it, they had far more engagement from these girls, and also a better kind of health outcome. Just briefly resting on this area of post-traumatic slave syndrome, because this area is just kind of emerging, and I've put kind of Black Panther here because I really love the movie, and I thought it was an excellent example of decolonizing cinema. And you could see two characters, Prince T'Challa, who was never colonized. He came from Wakanda, that was never colonized, so it was far more easier to have compassion and nobility and magnanimity. Prince Ndaka, he was affected by all of the downsides of a colonized ethnic group, and the anger and the resentment that ran in his veins ran deep. So that's a very interesting film, and there are some publications at the bottom of this slide which you could pause and look at. And as I said before, in decolonizing LGBT, that colonial times, any kind of diverse expressions of human sexuality were not allowed, and even had the death penalty. And in some countries of the world that have those old colonial rules, those still exist. But in terms of maternity care for LGBT plus, we just got to develop non-judgmental access to healthcare for couples that are having babies. UCL Anthropology, and I'm referring to my institution because it's been doing quite a lot of work in this area. The UCL Anthropology ran a wonderful summit called Flourishing Diversity, and it really kind of allowed us to see how recentering Indigenous values is so important at this point in time with climate change and sustainability, and we're talking about recentering planetary health, okay, and also understanding that a lot of our drugs came from indigenous medicines and plants, and actually acknowledging that instead of culturally appropriating them. And in terms of the well-being agenda, in terms of acupuncture or many of the modalities that massage and that women are using, yoga, this has an implication in maternity care. So as I said, cultural appropriation is the oppressed culture, aspects of the oppressed culture being taken out of context. I mean, you can go a little bit overboard with cultural appropriation and kind of squash and stifle multiculturalism and inhibit sharing of good practices. So it's not a black and white area, it is a grey, but respect is the central tenet, really. And so in all of these areas, in mindfulness, yoga, baby carrying, rebozo, there have been heated debates about cultural appropriation and, say, white healthcare professionals or doulas or midwives demonstrating these techniques without properly reflecting on their cultural origin. But I say the key word is its respect and the way in which you demonstrate that the knowledge was shared. But it's inconceivable that Indigenous people can fly over here and teach us all of these things, which are very beneficial for all women. So there has to be some balance of area. But any kind of attempts, for instance, in the present clinical environment to incorporate yoga, which has randomized controlled trials saying it helps women, or acupuncture that has quite a body of evidence showing how helpful it is with women, or reflexology, or yoga, even for the pelvic floor. There is a policy now amongst commissioning groups that have limited the incorporation of any of those things into the NHS because they're not on NICE guidelines. But NICE doesn't actually, NICE, which is the National Institute of Clinical Excellence, doesn't necessarily have guidelines on everything, and sometimes they are behind scientific knowledge, and there are other places where you can that have that hold research knowledge, such as the Cochrane Review or individual studies. And I think in this area, which there hasn't been much of a public consultation about it, but they have consulted with some people, this is where I think patient voices and experience count in terms of humanizing pregnancy care, or overturning the kind of imbalances between what is a legitimate form of treating people and what is not. And there are conversations going in terms of decolonizing birth, in terms of training Indigenous doulas. That is an act of reconciliation, from a Canadian publication. Decolonizing birth is very important. This is from Native American tradition. And then a kind of a book that's known, which is Midwives and Nurses, that are known by quite a few midwives, but I don't think any obstetricians have really read it. But it's clear that midwifery has been the victim of kind of colonization by Western biomedicine, but that perspective is only really vocalized by the midwives that understand that history, as it were. So anyway, those are all aspects, and that's aspects of history. But what about modern things? I think Black mums are looking at, I can see stuff in social media, empowering apps, digital platforms where they can compare ratings of healthcare providers so that they can make informed decisions. And so these sort of things are developing that are modern and new. I have also seen that people of color wanting to sort of auto-segregate themselves. I mean, we've come from segregation to integration, but then integration in society has not fully happened. And so people, to make themselves safe, there is talk about Black women's groups with Black midwives. And I can understand that that's wanting safety. But if you can see in terms of a historic loop going around, it would be better, I think, that society was fair to all individuals. So decolonial classic books that are around, that are talked about, is Renee Eddy Lodge's Why I'm No Longer Talking to White People. You can just about make it about race. And this is something that she wrote when she got really fed up with all of her kind of work to decolonize for equality, and she got fed up that her voice wasn't heard. And as soon as she wrote this book, she said loads of white people wanted to talk to her about the subject. So I wish it engaged more people. And then there's a book called White Fragility, about why it's so hard to talk to white people about racism. And these are both bestsellers and are in Waterstones. So there's certainly books to understand this thing about fragility, the people that have held the historic reins of power and haven't really understood the disempowerment that other peoples have, and they because their lens doesn't see it, they don't realize it exists. And I've heard people when they hear the membrace statistics say, is it really that kind of difference? I find it hard to believe, and that's that kind of refutation going on. So I would say the next steps, obviously, diversity and equality in healthcare is very important, and that is more of a top-down issue, tweaking policy. But decolonising has a more active kind of quality. It's about disrupting stale hierarchies in healthcare, and so in terms of healthcare, we've got to signal the importance to our managers, perhaps get cultural safety into human factors training when we train for obstetric emergencies, and oh, sorry about that, maintenance, and kind of really look at going forward with patient and public involvement. I think the Royal College of Obstetricians and Gynecologists are doing that. The Maternity Voices Partnership's doing a good job with that, and with the Royal College of Midwives. So those things are happening. So really kind of summarising the areas that I've talked about: power imbalances in healthcare, maternal mortality, decolonising maternity healthcare, and cultural safety and privilege fragility. Those are kind of main concepts that I wanted to get along. And I've got some references here which people can pause there. I mean, they're mainly my stuff, but there's a lot out there, and I have to acknowledge from UCL Medical School and in the generation, especially some of the earlier slides, my colleagues, Faye Gish and a medical student called Hope Chow. So that's what I wanted to say. I'll stop sharing there.
Yeah.
But Charlotte, have you got any questions?
I don't know yet. It's a lot of information, and I'm familiar with the subject because it's an interest of mine. And still, it's like you said on a few times, and at the very beginning, that it can be challenging for people to hear that there is systemic bias, that there's these things. So I'm coming from a position as a white middle class person who has to challenge the way the system has worked through me and my own privilege, and I don't see it. And so exactly like you said, there have been times when it's been pointed out to me, and my initial reaction is defensiveness. And because I'm interested and have that awareness, I can go, oh look, I'm feeling defensive, and then look at it without throwing it back out. And I know not everyone's having that, so then you can end up with conversations where the wounded parts of kind of wounded people arguing, and so I'm like, okay, come in to yourself first, and I can still feel that. So I find it's a really great subject to keep talking about, it makes me emotional and to have the humility and respect when it's coming back to humanity, and the humility and respect. And I'm also really grateful for you to sharing me that, to hear that, you know, at the high levels in the system, there are people caring and thinking about this and making a difference, like yourself, to do that. So as you said, you're saying we want women's voices, and I'm hearing that the women are in the system, outside the system, everywhere. So I'm really grateful that you shared all that information. I think when people can watch and pause and listen again, and really invite people to consider what for themselves, where they fit in, and to make changes in the world for the better for everybody, like you said at one point, for the system to be fair for everyone, again, the humanity. And for me, the first time I ever came what I call colonial mentality was when I first travelled outside of Europe and into Nepal and Thailand, and I suddenly realised that I was holding this consciousness that I called colonial mentality, which is interesting, of like, well, Britain's great, Britain's the best, Britain conquered the world, you know. And I'd never questioned it, because like you said, my teaching 30 odd whatever years ago in school was all from the white male perspective of colonial conquering the world, my geography, everything. So it's really great to see how change is happening and how that can change things in birth, which is my particular area of interest. So I'm really grateful to have this conversation.
Yes, I say it is a conversation, because I certainly don't think that I have any answers, except that the conversation is, I find, challenging my own, from not knowing what it even meant about 2 years ago to where I am up to now, in terms of presenting with my colleagues to, say, other medical schools in the country. So anyway, I'm glad you found that useful.
Yes, I did. And I think, you know, with any conversation, you have to start and then see where it leads. And I think answers come out with each individual person, and it will be a great thing. So I don't know if I have any specific questions because it was,
Okay.
obviously a well thought out presentation and lots of information in there to digest. And I know personally, I always, in the everyday circumstance, looking out the window at the people passing, I always kind of take it back into me. What does it mean to me? What can I do? I'm coming back again, like humanity, respect, humility, and kind of love for people and for wanting people to be happy and empowered. I know they're kind of cliche words, but I don't know how else to describe it really. And particularly in birth, when that's my area of interest for women, saying what they want to have in birth and experience. And like you've talked of the colonization against midwives, it's probably particularly clear in, say, America, where midwives aren't the norm, whereas they still are here. And then I'd like to see more of that balance, like you said, of the women coming in. I'd also love to ask you, if I may, about your own experience of becoming a mother and how that transformed you personally, because I think it's quite a transformative thing for every woman.
I think you're right. Well, I think for some women, it doesn't have to be transformative, but there is definitely a kind of portal into personal transformation or sex or self-actualization or whatever people want. And what struck me is that I was never taught that in medical school, and that I discovered it for myself. And it was actually because with my pregnancy I was taken away from my usual environment because of pelvic girdle disorder. I couldn't walk, I couldn't get there, so I kind of got forcibly removed from that culture and started listening to people and childbirth preparation classes that I wouldn't have ordinarily encountered. And through that, and I suppose through the stilling, because you can't move much with when your hips aren't working well, I think I just became more aware of my body and what was going on with it, and had a tangible sense of connection with my baby and what my baby wanted. It's highly intuitive, and I would never, for instance, I would have always wanted a birth in a birth institution because of my previous kind of experience in maternity, and also I'd always envisaged that hospitals were the safest place. But it's quite interesting to me that I suddenly, in terms of just feeling my baby, started feeling that actually I don't need to do it in hospital. In fact, my body will do it probably best out of hospital. So I ended up having a home birth, which I hadn't ever anticipated wanting or feeling that was the right thing, and it was hugely empowering. But I have to say that, and I've said this I think in someone else's blog, that if, for instance, I had had the opportunity to be pregnant again and the baby wanted a cesarean because of whatever reason, and I sensed that deeply, I would go with that. And so I would say my kind of message is that inner wisdom that can awaken. And I think that has something to do with physiology. We do know that increasing oxytocin increases what the psychologists call interoception, an internal awareness of your body integrity. And so I think in some women, as pregnancy progresses, there is an opening into a different type of sense of themselves, sense of their bodily integrity. So that happened to me, and so I realized that there was more knowledge than was taught to me in medical school and in postgraduate obstetrics and gynecology, and because of the sort of empowerment that I felt, I suddenly became aware of the power imbalances which I wasn't aware of before. So the whole thing really transformed my perspective on maternity and birth.
Yeah, wonderful. And yeah, I'm just thinking about your story, but I love what you said about how it was like in dialogue with your baby, what the right place was. It wasn't preset, because I think it's quite common. A number of women I've spoken to have had an idea of where they thought they wanted to give birth. There's a number of people on this summit actually that say, well, halfway through the pregnancy, my baby was telling me they had a different idea for me. And I think it's really important, because listening to that inner wisdom is the knowledge that you can't get from say clinical tests. You might be, like you said, your baby might say I want a cesarean, and there might be a really good reason for that that's not showing up on a clinical test, and you listen to that, honour that. And the same with you with the home birth, that your body unfolded better in your view. I really like that. I'd love to see science embrace embrace more of that. And I feel like it's scientific and we just can't measure it.
I know. I've got a friend of mine who's a doula, a home birth doula, who when she became pregnant, surprised herself at the end of pregnancy with an inner wisdom kind of feeling, saying, "No, my baby wants to have a cesarean," and she'd supported so many women in home births. So that was an interesting reverse story that I heard of subsequently.
Yeah, it's all about the inner wisdom. And yeah, and I would like to mention your book, because you wrote a book following your home birth called The Heart in the Womb. Is that correct? Is that right?
Yes, the heart in the womb, the exploration of human love in society. Well, it's human love and social cohesion, I think, is the broader title of it. Yes,
Yeah.
and I think there's plenty of evidence to back that. If women are looked after really well, have continuity, develop that oxytocin mechanism within themselves, and have the breastfeeding and the kind of infant connection that arises with that, is reflected, I think, with lots of social occasions of better cognitive development in their babies, and who contribute to society later on. So it is, women are just such an important cogwheel in maintaining. And with the world as it is now, one wonders what has happened in terms of maternity care and women being allowed those opportunities. Not all women want those opportunities, and that's fine. But I think there has to be recognition of the importance of mothers in society.
Yes. Yeah, I contrast quite often the way in my husband's culture in the Gambia, the mothers are very seen as very important, very much so in comparison with here. And the work that you do as a mother, he's always saying to my children, look at what your mum does, in a really honouring way. And it's a different cultural, in my own family, that I can see the different approaches and really appreciate, where particularly if I'm tired and working hard, and sometimes I see other women doing that and working hard like me, and they're not maybe getting that appreciation for what they're doing at home. And but I'm getting it in my own home from my husband, and that makes me feel good, even if the work is challenging, how it is as a mother when you're tired or no sleep. So yeah, I'd love to see that as well. And do you have any final thought that you would, if there's a woman listening who wants to, who's not feeling so confident yet about giving birth, what would you suggest to them? What would
you? Well, as a wish list is that I hope she has continuity of care in terms of midwife or doula, because I think that relationship of continuity is just really important. I think that's what really helped me become more confident in myself and my body, and that would be my wish. But if the system could set it up that way, that would be perfect.
yeah.
So yeah, that's it's kindness and compassion and relationship that really help. But if you don't have it, there are some great kind of workshops that help you. I'm a great kind of fan of pregnancy yoga, in terms of just relaxing, being kind to yourself, and becoming familiar just with your body, because in modern society women are so in their head, so intellectualized, that we have lost that kind of connection with our bodies. And I think birth is such a bodily experience that reconnection with your own body as well as your mind is so fundamental and important. And good childbirth preparation classes help you do that. So that's what I would suggest.
Yeah, definitely. Did you find it easy or hard? Because you're in your job, you're quite working in the intellectual area in a way. Did you find it harder to let go of that when you were giving birth yourself, or did you find that your baby and the birth and your body led the way?
I think if you read my story,
I haven't
I
read
had
it.
no I had no choice. I had no choice. Nature kind of wrestled me down and took from all of that. So yeah, and it wasn't until I stopped breastfeeding that really that whole intellectual mind came back, and I reconsidered, should I redo my book, update it, but actually that was written in a particular state of mind, which is not my intellectual scholarly mind, and it could only have been written in that time frame when those attributes were not as strong as they are in my brain now. So I can't really rewrite it. It's kind of the story of what happened to me and the environment of birth at that time.
Wonderful. Yeah, I guess you could add a chapter on from now, but you couldn't, like an epilogue, but you couldn't change what you've written. I'll have to read it. I haven't been able to have time to read it yet, but I would love to read it.
That's okay.
Yeah.
Well, very nice to meet you, Charlotte.
Yeah, thank you. You too. I'm really grateful for you sharing your lecture, and thank you for your thoughts and thank you.
All right. Okay. Bye.
Bye.